So we're going to start right away with Dr. Jean Joris on postoperative pain management after colectomy.
Pain management after colectomy must fulfill several requirements. It should facilitate early feeding and early mobilization, two essential items of all enhanced recovery protocol. Early feeding supposes prevention of postoperative ileus and postoperative nausea and vomiting. Early mobilization requires prevention of postoperative hyperalgesia and of orthostatic hypotension and avoidance of catheter and drain. These goals can be achieved thanks to balanced analgesia to reduce the consumption of postoperative opioid, epidural analgesia and intravenous lidocaine, which both speed up the return of bowel function, and NSAID, who have also a direct effect on the postoperative ileus. Intraoperative antihyperalgesic drugs and opioid-free anesthesia reduce postoperative hyperalgesia and reduce the consumption of postoperative opioid. Therefore, early mobilization will be facilitated. I will now focus on the place of epidural analgesia, intravenous lidocaine, and NSAID. First, epidural analgesia. Epidural analgesia results in multiple beneficial effects after colectomy. Opioid-sparing effect, both intra and postoperatively. Reduction of the duration of postoperative ileus. Antihyperalgesic and anti-inflammatory properties. Reduction of the surgical stress reaction. Excellent analgesia even during mobilization, and a reduction in the risk of postoperative respiratory complication. However, epidural analgesia is also responsible of side effects which can limit its use in case of very efficient enhanced recovery protocol. Indeed, epidural analgesia will worsen intraoperative hypothermia and will require more fluid load in response to hypotension and vasodilation. Postoperative urinary retention may necessitate prolongation of the bladder drainage. Orthostatic hypotension can compromise early mobilization. And finally, analgesic transition after the interruption of epidural analgesia still remain a challenge. For all these reasons, epidural analgesia is no longer recommended for laparoscopic colectomy. In case of open colectomy associated in an enhanced recovery program, its use is controversial. Intravenous lidocaine shares multiple benefits with epidural analgesia, yet it reduces also intra and postoperative opioid consumption. It will shorten the duration of postoperative ileus. It has antihyperalgesic and anti-inflammatory properties. It is a good analgesic to treat visceral pain. However, it does not result in urinary retention and in orthostatic hypotension. However, if we compare the analgesia when using intravenous lidocaine and epidural analgesia, it is clear that the efficacy of IV lidocaine is less than epidural analgesia. However, if you combine IV lidocaine with a very efficient systemic multimodal analgesia and with stem block, you can compensate for this potential weakness. Let's finish now with NSAID. The use of NSAID for colectomy is somewhat controversial. Indeed, on one hand, the opioid-sparing effect of NSAID is certainly welcome to improve postoperative nausea and vomiting and to reduce the duration of ileus. It is also very interesting because the NSAID have direct effect and can speed up the return of bowel function. There are good analgesic and antihyperalgesic, and in fact, as you know, NSAID is probably the most efficient component of balanced analgesia. However, NSAID have been demonstrated to increase the risk of anastomotic leakage. And recent meta-analysis, however, suggest that you can use NSAID for colectomy if it is given not longer than 48 hours and in the absence of other risk factor for anastomotic leakage. The risk of intraoperative bleeding can be significantly decreased if you give it at the end of surgery. And finally, don't forget to consider the risk of acute renal failure, particularly if you have marked intraoperative hemodynamic instability.
Thank you very much, Jean. So thank you for this overview on the actual gold standard on analgesia after colectomy. So before we have an online question, I'd like to ask you about epidural. How do you choose whether or not to use an epidural in a patient, and in which patients?
Okay, as I mentioned, it's a very controversial subject right now. Definitely, in case of laparoscopic colectomy, the literature is clear and does not recommend anymore epidural analgesia. In case of open colectomy, using epidural analgesia is more controversial. If you work in a center where you have a very efficient enhanced recovery protocol, I think personally that the side effect that I've been presenting will limit and will compromise early mobilization. Furthermore, at least in my experience, and I have experience of epidural analgesia for more than 25 hours, the analgesic transition, when you interrupt epidural analgesia, still remain a challenge, and I have not find so far the perfect solution. However, we continue to use epidural analgesia in case of severe COPD to reduce the risk of respiratory complication. Now, if you work in an institution where you have trouble, where you have problem to provide adequate analgesia after open colectomy, and if you are familiar with epidural analgesia, continue to use it, of course, because I remind you that not long ago, epidural analgesia was a prerequisite to enhance recovery protocol.
Okay, thank you. So in practice, you use it, right?
Less and less,
okay.
Except for COPD patients, we don't use it anymore.
Okay. So I have a question about IV lidocaine coming from Belgium. So you presented to us that it's an alternative, and the question is about association. Do you associate another nerve block, like a TAP block, for example, with IV intravenous lidocaine? And is there any benefit of this association?
Yes. In fact, we combine routinely intravenous lidocaine and TAP block. As I mentioned in my presentation, intravenous lidocaine shares multiple benefits with epidural analgesia. However, the quality of analgesia is certainly less than after epidural analgesia, and one gap of the analgesic profile of intravenous analgesia is probably parietal pain. And that's the reason why we have decided to combine IV lidocaine with TAP block. Because TAP block, when well performed, I mean posteriorly, because too many people, I think, perform the TAP block too anteriorly. This is not the subject of today, but I think this is a very important point. If you combine with TAP block will provide prolonged, certainly more than 24 hours, a good parietal analgesia. However, we must keep in mind that TAP block result in significant plasma concentration of local anesthetic. And I think we must add adrenaline to all anesthetic solution we use for TAP block to reduce the absorption of local anesthetic. By the way, whatever the local anesthetic you use, ropivacaine or levobupivacaine, there are data in the literature for both local anesthetic. And because of the risk of systemic toxicity, when you will start IV lidocaine, you must wait at least 40 to 45 hours to have the time for the peak to have decreased.
45 minutes, you mean?
A minute, yes.
Yeah, you said hours.
Oh, sorry, 40 to 45 minutes, sorry.
Yeah, it was the end of my question. So you, in practice, you stop intravenous lidocaine 40 minutes before the end of surgery, and then you do the TAP block?
No, no. In fact, in our practice, we start with TAP block. And so after the induction of anesthesia, we perform the TAP block, okay? And we wait 40 to 45 minutes, and we start IV lidocaine.
Okay. And then do you keep IV lidocaine after surgery?
In our institution, we keep it for 24 hours.
Okay. Thank you. With a special surveillance or?
No, for several reasons. Because in fact, if you looked at the blood level of lidocaine, if you perform a prolonged infusion, you will have about this the same plasma concentration of local arsenic as the one you get after any infusion for nerve block. And when you perform nerve block, I mean, you don't worry about this.
No.
So that's one point. The second point is that after surgery, as you know, you have an acute, you have inflammation, and you have an increase of the alpha-1 glycoprotein, which is a drug which will stick the lidocaine, and therefore you will reduce the risk of systemic reaction. And finally, as you know, the appearance of the side effect of lidocaine are very progressive. And if your nurse are taught how about all these signs, it is very easy to recognize the early sign and to stop the infusion. And very quickly, if you stop the infusion, within 5 minutes, all the signs will have disappeared.
So I have a question. Well, it's also about lidocaine. They're asking if it's validated in practice, meaning is it okay to use lidocaine, IV lidocaine, even if you know that on the bottle it's written that it shouldn't be used intravenously?
That's what is written in France. But for example, in Belgium, we have several preparations where it is clearly written IV. And for example, Bibrone in Belgium, and I'm surprised it is not the case in France, we have a solution called Linezol on which it is written IV. And the funny thing is that right now we are in shortage of this drug, and we have found another one on which it is also written IV injection.
Okay.
So I don't know why in France you have this problem.
It's a specific French problem. Okay.
Maybe.
All right. So we have time for just one quick question about NSAIDs. Do you recommend NSAIDs after colectomy? Do you use them?
Yes, we use it. I mean, anytime we have no contraindication of NSAIDs, the usual one, and anytime we don't have risk factor during surgery. I mean, if you see that, if you notice that your surgeon have some suspicion about the quality of their suture, of their anastomosis, I will not use it. That's the reason why, that's the second reason why we wait until the end of surgery before administering the NSAID.
Thank you very much, Jean.